Hi everyone, in today's video I'll be going over alpha and beta thalassemias. Overall, before I start, thalassemia is an inherited blood disorder which causes the body to not create enough of the protein called hemoglobin. For some quick overview, I'll be going over the background information, the pathophysiology, some of the clinical symptoms, the key investigations, as well as the management. Now let's start with alpha thalassemia. It is an autosomal recessive condition which affects chromosome 16. And within it, there's 4 genes at play. Just like the name suggests, there are defects in the alpha globin chain. And it is estimated that up to 5% of the world may be carriers for alpha thalassemia. And the prevalence may be up to 1 in 10,000 in tropical and subtropical regions. There's different variations of alpha thalassemia. So on this diagram, purple squares represent a functional gene, and the white squares represent the alpha thalassemia gene. In a person with 4 purple squares, or 4 functional genes, they are normal. They have no alpha thalassemia. If you have 3 functional genes and 1 alpha thalassemia gene, you're considered a silent thalassemia carrier because you will not be experiencing any symptoms. You can also have alpha thalassemia trait, and that occurs when 2 out of the 4 genes are affected. This can be either homozygous, where there's a pair of a functional and an alpha thalassemia gene each, or it can be heterozygous, where you can have a pair of functional genes and a pair of alpha thalassemia genes on 2 separate parts. Next, you can also have HBH disease, which is where you only have 1 functional gene, and the most severe one is HB Bart's hydrops fetalis, where you have no functioning alpha thalassemia genes. In terms of how they present, in alpha thalassemia trait, you would have no symptoms, and there might be mild anemia present, but it would not be symptomatic. In HBH disease, you will have enlarged spleen, jaundice, fatigue, and patients may even have bone deformities. Whereas with hydrops fetalis, you would see things such as swollen liver or an abdominal swelling, placental thickening during pregnancy, but very often death because of how severe the condition is. With regards to the investigations, a full blood count will show you a microcytic anemia. The hemoglobin electrophoresis can help diagnose globin abnormalities. However, in alpha thalassemia, it tends to be normal, which is why you need to perform a DNA test, which itself looks for genetic abnormalities and can pinpoint to the diagnosis. You should also do an iron ferritin check to rule out any iron deficiency, and it should be normal in patients with alpha thalassemia. With regards to the management, those with silent or alpha thalassemia trait don't require any treatment. Those with HBH disease might require regular blood transfusions, a splenectomy, or a bone marrow transplant, which would be considered curative. Next, I would like to move on to beta thalassemia. Again, it is an autosomal recessive condition, however it affects chromosome 11. There are 2 genes at play, and there's a dysfunction in the beta chain. Again, you can have different variations of beta thalassemia. With regards to severity for beta thalassemia, you can have a gene dysfunction or a gene deletion. So patients with thalassemia minor would have 1 functional gene and 1 dysfunctional gene. In terms of thalassemia intermedia, you have 2 options. It can be a patient who has 2 dysfunctional genes or a dysfunctional gene and a gene deletion. And then lastly, for thalassemia major, you would have a patient with 2 gene deletions. However, this classification between thalassemia intermedia and thalassemia major in beta thalassemia patients has less to do with whether the patient has a gene dysfunction or a gene deletion, but rather whether they themselves are dependent on transfusions or not, and that is how you would grade the severity. However, I think it is important to know the different options, particularly for exam purposes. For transfusion-independent patients, you would see things like headaches, pale or yellowish skin, or fatigue, whereas transfusion-dependent patients would see facial bone deformities, delayed growth and development, dark urine, splenomegaly, and possibly osteoporosis. Investigations are the same as in patients with alpha thalassemia. However, here the hemoglobin electrophoresis would be diagnostic, and therefore a DNA test would not be necessary. For thalassemia minor or transfusion independent, you do not need active management. Monitoring is sufficient. Whereas for transfusion dependent thalassemia, you would require regular or occasional transfusions, as well as iron chelation in order to prevent iron overload. This was a brief overview of both alpha and beta thalassemia. I hope it has helped you understand the topic a bit better. If you have any questions, feel free to leave them down in the comments. I hope you enjoyed this video. Thank you so much for watching.